thanks very much for that kind introduction. It's a delight and an honor to be here, and particularly in this neighborhood, because although Diane and I come here as experts, I know many people in the audience, and I know a lot of the expertise that you have in palliative care, whether it's people like John who have developed the palliative care service, Jen McElveen, who's a nurse practitioner, Susan Lord from Delaware Hospice. These are all people I know and colleagues who I respect, and they're in your backyard. They're here. So Diane and I will wander back to Philadelphia and New York this afternoon, but you have an enormous reservoir of experience and skills in the kinds of things that Diane and I will be talking about today. So I hope we can add something to the mix, but keep in mind you have a wonderful set of resources here, and we can add to that. But you really are very, very fortunate. I would encourage you both in the discussion period and then in the coming days to seek out the people sitting to the left of you and to the right of you to add to what we can offer. I would also say that I'm absolutely delighted to go in this revised order ahead of Diane Meyer. I've spent far too many of these sessions trying to follow her, which is not in a position that any mortal wants to be in. So this is absolutely delightful. I can give my piece, and then I can get out of the way, and you won't have her presentation in mind as you're listening to mine, unless you were at Medicine Grand Rounds, in which case I'm just toast. I just got back from Nepal. I was there for a couple of weeks. I got back 5 or 6 days ago. And one of the neatest things to me about I was working in a hospice there and then spent some time backpacking. And one of the neatest things about traveling Nepal to me was the combination in a single backpacking day of 15 miles or so, being up on ridge lines and on passes with a view literally for hundreds of miles. But then an hour later, being able to dip down into a valley, wander through a village, being invited into somebody's house for tea. So amazing views you can see for hundreds of miles, but also that one-on-one interaction with folks. And I've got to say that the people in Nepal are among the nicest, warmest, most welcoming of any of the several dozen countries I've been in over the last 10 years. So that was a real pleasure and a privilege. And I wanted to share this picture of Nepal and tell you that story because that's what I'd like to give you in the next 45 minutes or so. I'd like to give you both a combination of that 10,000-foot view, but also drill down and give you a story along the way. So let's start with the story. This is a guy named John who I took care of 8 months ago now. 50-year-old man admitted to one of Penn's hospitals by way of the emergency department for management of pain due to metastatic colon cancer. Had severe pain on admission for which a medication review revealed only Tylenol. That's all he was on. Had been admitted 4 times in the last 6 months, twice due to pain, once due to nausea, volume depletion, once due to altered mental status, which in retrospect was probably due to nausea and volume depletion. His wife is clearly, when you meet him in the emergency room, and her very overwhelmed with caregiving, really wants to know about things that would help her care for him. Talking with him later on the floor, one of the oncology floors, was very, very clear that he did not want to be there. Doesn't want to be in the hospital, doesn't want to go back to the hospital. And one thing that's really telling is that last sentence, that every time you get to the hospital, you get worse. You get more tired, you get weaker, bad things happen. He didn't actually say that, but I would, and many of you are nodding, you all agree. The one place we all want to avoid, whether we're patients ourselves or family members of patients or healthcare providers, is the hospital. Things don't happen well in hospitals. And his wife knew that. And that was the real tragedy of this story. The way he got to the hospital, which many of you probably had begun to guess, was that he developed pain that was severe. His wife didn't know how to help him, called the oncologist. The oncologist was out of the country. The oncology fellow was willing to help but didn't have a DEA number. She tried calling friends, neighbors to help get him to a clinic. Nobody was available, so what did she do? If you had a husband who was suffering, needed help, had no way to get him to a clinic, call 911, right? So that's what she did. So she called 911, the ambulance crew came, picked him up, took him to the emergency room, wound up in the emergency room. In theory, he could have gotten a prescription for oral morphine and gotten sent home, right? But once you get to the emergency room, what happens? Somebody gets x-rays, somebody gets a CAT scan, somebody certainly gets blood tests. And you've got a guy with metastatic cancer in the emergency room. Once you start getting blood tests, right, you have a low potassium, you have a high sodium, you have a low glucose, you certainly have a low hemoglobin, high calcium. I've just listed 5 reasons for him to be hospitalized, and so he was. So you have a guy with pain who wants to avoid the hospital, who winds up in the hospital for pain management. Just to give you a sense of how broken our healthcare system can be. So here's where I'd like to go in the next 40 minutes or so. I'd like to talk briefly about some of the challenges from the health system perspective of patients like John. How do we do a good job of taking care of him and patients like him, and sometimes how do we fail, as we did arguably in John's case. I'll try to convince you that we need to be thinking much more as a health system about home-based palliative care. I'll talk a little bit about hospice as one way of providing home-based palliative care, and then I'll turn that around and try to convince you that although hospice is a partial answer, it's not all of the answer, it's not where we need to be. And then I'll start talking about an alternative, including the CLAIM project, the CMS Innovation Project, and I'll tell you a little bit about that as a way of providing what we hope is relatively comprehensive palliative home care for patients, and then I'll show you some results that we're getting out of year 1. So again, trying to toggle back and forth between the story at a one-on-one level and then some data and research on the other. So challenges of chronic serious illness, we saw pretty much all of those in John's case. For health systems, though, patients like John are also challenging. 30-day readmissions, poor satisfaction. A lot of the things that happened to John were incredibly stressful for him and his wife, but they're also, in a different way, stressful for health systems. And you could argue that we really shouldn't be thinking about these. We shouldn't be thinking about these 10,000-foot level issues. What really matters is what's on the left-hand side. What really matters is what is important to patients like John and his wife. As the Christiana motto has it, what happens to our neighbors and how they feel and how they experience healthcare. And I think that's true. But as one of my roles now as Director of Hospice and Palliative Care for the Penn Health System, I need to think about stories like John's, but I also need to think about how to message stories like John to people like Ralph Muller, who's the CEO of the Penn Health System. How do I use a combination of stories and data to convince him that we need to build palliative care? And so I've really begun to think of the things on the right side of the slide as kind of the flip side of what John and his wife experienced. Not more or less important, but important in a different way, their leverage. I mean, those factors on the right side of the slide, that's what I use every day to convince my colleagues, to convince leadership at the University of Pennsylvania that we really need to invest in palliative care. I'm not saying that stories don't matter, stories do matter, but ultimately what our leadership also wants to see is ways that we can improve satisfaction, ways that we can decrease 30-day readmissions, and some of these other outcomes. So where do we start? If we wanted to start thinking about how to help a patient like John specifically, and this is the focus of where I'd like to go in the next half hour, especially if we want to focus on how to help him stay at home comfortably and safely, where do we start? Any idea who this is? Willie Sutton. I never would have recognized him, but some of you did, right? So this is Willie Sutton, who apparently, story has it, when asked by a biographer why he robbed banks, said that I rob banks because that's where the money is. It turns out, by the way, that later in his life he actually clarified and said, that's a great line, I wish I had come up with that, but I didn't really say that. I really rob banks because I like it. But this is actually much more useful for this talk, so just focus on that for a moment. So where is the money when you're talking about patients like John? Again, I don't mean to dismiss the suffering that he and his wife went through, but again, thinking in terms of leverage, thinking in terms of value, thinking in terms of a value proposition for palliative home care, where is the money? The money, I've begun to realize belatedly, I think, as I get more into an administrative role, is in that transition. It's those patients who spend all of their time at home and who occasionally flip over, as John did, and wind up in the hospital. There are opportunities for cost savings by reducing length of stay, certainly by getting patients out sooner, and to some degree by reducing 30-day readmissions. But the real opportunity is taking this population of home care patients, this population of patients like John who are happy at home, want to stay at home, want to avoid the hospital, and keeping them out. That's the big opportunity for cost savings. The other reason, by the way, to help people stay at home is that's where, as I alluded to before, that's where we all want to be. Good data from some work that Joan Tino's done in a national mortality follow-back study, the first reference here, quality of end-of-life care. In general, family members tend to be much more satisfied with care when that care happens outside of a hospital. In fact, the worst place to die, if you look at her data, is in a hospital. That's changing due to the work that Diane and many others have done to build palliative care services in hospitals. But in general, think about where you would want to spend your final days. Think about options that are available to you. Develop a list, and I'm pretty sure that a hospital would not be on the top 10 of that list. The other data, unrelated to palliative care, but I think very interesting. I've gotten very interested in reading lately some of the literature on hospital-at-home programs. And the data are mixed. You know, some hospital-at-home programs save money, some don't, some have better outcomes, some are about the same. But the one common theme that runs through a lot of hospital-at-home programs is satisfaction. Outcomes may be different, costs may be different, but patients generally like these programs because these programs help them to stay at home. I'm not saying that's the only benefit to hospital-at-home programs, but that's one that stands out pretty clearly. And our pediatrician colleagues have known this for years. They know what John realized a long time ago, that kids do worse when they come into the hospital, families do worse, dynamics break down. The most helpful thing you can do to a chronically ill child and his or her family is to help him or her stay at home. So our pediatric colleagues have known this for years, which we're just beginning to figure out. So what about hospice? Just a show of hands, how many people here are from a hospice organization? So many. And I am too. I'm the chief medical officer of Penn's hospice program. A lot of my research focuses on hospice. I have been and continue to be a big fan of hospice, as I'm sure many of you are. There's actually pretty decent data showing that hospice is effective at achieving many of these outcomes and some that I didn't mention. The data quality are good. We're never going to have good randomized control trial data. Think about how that would work. You'd take some people who wanted hospice and you wouldn't refer them, other people who didn't want hospice and you would refer them. That's a randomized control trial that would be entertaining to hear the IRB discussion of, but it's not one that I really want to propose. So most of the data we have are propensity score matched case control studies, or some combination. So decent quality data, but not perfect. In general, though, those of us who either work in hospice, refer patients to hospice, are pretty convinced that hospice has a lot of value to bring to the table. Hospice, though, isn't necessarily the best solution for every patient at every stage of illness. And I love this flowchart because it summarizes what a lot of healthcare leaders think. As I realize as I'm talking to them, this is kind of the way their brains process information. You take a complex problem, you break it up into a couple of key components like does it move, should it move, and then that produces a solution that involves either WD-40 or duct tape or some combination. And I find that whether you're talking about decreasing surgical mortality rates, improving rates of 30-day readmission, improving satisfaction, many healthcare leaders tend to think in terms of WD-40 and duct tape. And to some degree, I think that's often the way we think of hospice. Patients need better palliative home care program. We have hospice, therefore we need to get more patients into hospice sooner, which we do. I mean, our median length of stay in our hospice in Philadelphia is only about 6 days. And we have 20% of our patients referred in the last 24 hours. So I'm all in favor of getting more patients in the hospice sooner, don't get me wrong. But that's not the ultimate solution for all patients. And the best data to support that, I think, or if you look nationwide, our numbers at Penn's hospice are pretty bad in terms of length of stay, but nationwide they're not that much better. So nationwide, the median length of stay these days is only about 18 days. About a third of patients are referred in the last week of life and 10% in the last 24 hours. I don't know what the optimal length of stay in hospice is, but for those patients who enroll in hospice in the last 24 hours, at least in our hospice, that often means a patient referred from one of our hospitals to our hospice unit somebody who dies in the ambulance, bouncing over potholed Philadelphia streets between our hospital and our unit, that's not an optimal length of stay. Those patients either should have been referred much sooner or they should have had access to an alternative, but that's not good care. We could talk a lot about why that happens, why patients are referred to hospice so late. A lot of it has to do with the degree to which we all deny death. Nobody wants to think about end-of-life care. But a lot of it, frankly, has to do with hospice eligibility criteria. Patients need to have a prognosis of 6 months or less if the illness runs its usual course, and they must embrace a plan of comfort care, which isn't specifically defined based on hospice's interpretation of regs. On the other hand, what that means generally is a focus on comfort care, at least for that admitting diagnosis. For many patients, these criteria work very, very well. But for many, they don't. And for a patient like John, they didn't. Didn't want to be in the hospital, but still wanted some aggressive treatment. And there's a picture of a typewriter there, which you're probably wondering about. The story goes that back in the 1870s, as the Underwood typewriter company was just getting going, they started building typewriters, they started selling typewriters, people started buying typewriters, people loved their typewriters for the first week. After the first week, after they had a week of experience in typing, they got better at typing. They got better, they got faster, and as soon as they got faster at typing, once they exceeded 20 words a minute or so, then the keys started jamming. And it was at that point that people decided they hated their typewriters, and they started shipping their typewriters back, because everybody wanted a typewriter, but nobody wanted a typewriter that would jam if you typed too quickly. So the engineers who worked for Underwood, led by a guy named Christopher Scholes, scratched their heads to try to come up with a solution. Technically, they couldn't figure out how to keep these keys from jamming, but Christopher Scholes came up with a great idea that bypassed all of the technical issues. Any idea what it was? The QWERTY keyboard, right. So if you can't get your keys to type quickly, then you get users to type more slowly. And if you put frequently used keys far apart, if you make the keyboard as inefficient as possible, then people's typing speed goes down, keys don't jam. Obviously that's silly now because we all have electronic keyboards, but we're stuck with a keyboard developed 100 years or more ago, which is designed to be 20% slower than more efficient models. And I would argue that's pretty much what happened with the hospice Medicare benefit. David Stockman, who was Ronald Reagan's budget director, was worried that the hospice benefit would break the bank, that everybody would enroll in hospice. So what did he do? He created the equivalent of a QWERTY keyboard, right? Prognosis of 6 months or less, that knocks out a bunch of people. Must accept a plan of comfort care, that knocks out a bunch more. Effectively, you've slowed the equivalent of our typing speed in terms of hospice referral, and now you have people referred in the last days, sometimes hours of life. So David Stockman was happy, but we're stuck with this model that causes us to refer patients late and probably causes us to avoid referring patients who could benefit. You could ask, though, whether David Stockman was onto something, right? So those criteria slow referrals, those criteria delay referrals, but what if David Stockman was right? What if those criteria, prognosis and desire for comfort care, identify the patients who need hospice the most? Then some of those numbers that we're seeing, delayed referrals, low incidence of referrals, maybe that makes sense. Maybe we are getting the patients who really need hospice. I didn't think that was true, but I didn't really have any way of defining that. So some colleagues and I at Penn began a study a couple of years ago that was designed to try to figure out whether hospice eligibility criteria work. A couple of different versions of the study. What I'll show you now is just a cross-sectional study with patients with cancer and then family members. There was also a longitudinal component, which I won't talk about. Patients in the Penn network, and we talked to patients and families if physicians thought, their oncologists thought, that the patient would have a prognosis of 6 months or less if they stopped treatment, as close as we could get to hospice eligibility criteria. We use techniques of conjoint analysis interviews, which I'd be happy to tell you about offline, but essentially they're very simple techniques of marketing research that tried to identify the value that patients, consumers, place on various services by asking them to trade off different services. So would you like a nurse or respite care, home health aide, or a chaplain, along with obviously elaborate descriptions of what we mean by those. And then these options would be rearranged and patients would be given another choice and another choice and another choice until we can calculate or model the value that patients, and in this case families, place on each of these. And we could also sum them, right? So you could add up the value that patients and families would put on a variety of services to get some sense of how much they think they would benefit from the program of hospice services, right? So these are the services that we ask them about. You'll notice some of them are classic hospice services. There are a few thrown in there based on focus group testing, like a peer support group or meal delivery that patients, and particularly families, were telling us would be valuable to us, so outside of the Medicare benefit. Any guesses which was the most important to patients and families? Meal delivery, chaplain, visiting nurse, nurse's aide, keep going. Yeah, it was actually telephone case management. And I love this slide because it's, I think, silly, and it's a testament to how broken our healthcare system should be, that when you ask patients and families what extra fancy services would you want, they come up with something like telephone case management, which really should be a standard part of any healthcare system. But this is kind of the icing on the cake that patients and families really thought would be nice to have as a perk, when it really should be standard. So this is the question I posed to you a few minutes ago. Do hospice eligibility criteria identify those patients with the greatest needs? The answer is mixed. So in terms of prognosis, yes, it looks like they do. So again, this is a sample of patients and families with advanced cancer. We found significantly higher needs for the services that I just showed you for patients in the last 6 months of life. So partly, yes. The flip side to that, though, is that the other half of those eligibility criteria, a willingness to embrace a plan of comfort care, doesn't seem to work at all. In fact, in most subgroups, the trend was flipped, meaning those patients who wanted aggressive treatment actually had greater needs. You could think a little bit about why that would be. Our working hypothesis was that patients with cancer who want aggressive treatment are getting aggressive treatment, and aggressive treatment in cancer often means chemotherapy, radiation therapy, often surgery, which results in patients feeling weak, tired, having symptoms. These are exactly the kinds of patients that palliative care can help. So not only does the desire for comfort care not identify those patients with the greatest needs, we're actually probably steering people incorrectly if we're relying on that too much. Jess Fishman, who is a fellow then, is faculty now at Penn, did a subset analysis of this study looking at African Americans and found that African American patients were less likely to have hospice appropriate preferences. They also had greater perceived needs for services, and if you cross those two tabulations, what we realized is that African American patients whose preferences excluded them from hospice actually had greater perceived needs for hospice services than did white patients whose preferences got them into hospice. So not only do hospice eligibility criteria not work particularly well, they're arguably unfair at a population level. So back to John. 54-year-old man, multiple problems. You look at this list and you think about hospice services, visiting nurse, chaplain, social work, case management, involvement of a physician. You look at those services, you look at this list and you think, yeah, hospice really could help him. Prognosis, though, was uncertain, wants to continue receiving relatively aggressive treatment, doesn't want to be in the hospital, because who does, but wants chemotherapy, transfusions in particular, EPO, for a variety of reasons was not appropriate for hospice, or hospice wasn't appropriate for him, the way I usually frame it. So a lot of needs, but hospice wasn't a good fit. So what would ideal palliative home care look like for him? A comprehensive inpatient palliative care assessment, a seamless handoff to outpatient care and to home care, and these sorts of services while he continues to receive the treatment that would benefit him, rational, logical plan of treatment that would probably taper off over time and become less aggressive over time. There's really no way in our healthcare system right now to provide these packages of services. If he enrolls in hospice, it gets a lot of these services but has to forego treatment unless you have access to an open access hospice program. But without hospice, there's really no way to put that together. So I wanted to tell you briefly in the next 10 minutes or so as we wrap up about a project we have going on now to test what hopefully would be a new model to provide many of the services that hospice provides to patients like John who are not yet ready for hospice. And the conceptual model for claim is based on 3 components. First of all, advanced care planning. Think about John. He had clear but unrecognized preferences to avoid hospitalization. He didn't want to go to the hospital. His wife didn't want him to go to the hospital, but nobody else really knew that. Case management, I don't need to say anything more about that. Patients really shouldn't be admitted to the hospital for what could be managed with oral opioids. And the idea of calling an ambulance to manage pain is just crazy. And then symptom control, the same thing. So we've built claim, we've built the conceptual model on those 3 components. And our pitch to CMS is that if you do a better job at advanced care planning, do a better job at identifying goals for care, better job at symptom management, and most importantly, a better job at case management, you improve quality of care, improve quality of life, keep people out of the hospital, and reduce costs. So in thinking about how to design essentially a program from scratch, the first thing we realized is that we didn't want to design a program from scratch. And so thinking about what tools we had, we really wanted to identify tools, programs that were available. And many of you know the CMS Innovation Grant had a very short timeline for proposals, so we needed to put something together very, very quickly. The story goes that back in the 60s with the space race between the Americans and the Soviets, they solved on both sides of the ocean a lot of technical problems. One of the most prominent technical problems was one that you could have anticipated, but apparently nobody did, and that is that fountain pens, which were a prominent writing instrument back in the 60s, don't work really well in outer space for obvious and messy reasons. And so the Americans, being the Americans, put a lot of time and effort and money into coming up with a solution. And they created the space pen, which writes upside down and underwater and in 0 gravity. The Soviets, though, didn't have a lot of time, didn't have a lot of money, but they did have one thing we didn't have, which is a dictatorship. And when you have a dictatorship and when you have a group of scientists in a dictatorship, you can take those scientists, you can lock them in a room, and you can tell them they're not coming out until they come up with a solution, which is what the Soviets did. And so the story goes that they locked these scientists in a room on a Friday night, and early Saturday morning, the scientists emerged with an answer. And even better than an answer, they had a prototype. Any guesses what it was? A pencil, right. So our challenge then in putting this grant together was what's the equivalent of a pencil? What's something that's a tool we have readily available, easy to implement? What could we take off the shelf and begin to build into a palliative home care program? And we decided to use the Medicare Skilled Home Care benefit, right, which pays for nursing care, primarily nursing care and some physical therapy and limited social work services for patients who are homebound, meaning they have difficulty getting out of the home except for medical appointments, and who have a skilled care need, which includes many of the needs that are part of palliative care, like pain and symptom management. The logic was that it was an existing revenue stream. There are thousands of home care programs out there, which also means this is scalable. So if we could figure out how to turn a home care program into a palliative home care program, that then becomes something that would be of interest to CMS, hopefully, and something that would be scalable. So our design broadly is to include patients with a primary or secondary diagnosis of cancer who qualify for skilled home care, meaning homebound and a skilled nursing need, comparing claim services versus routine home care using a propensity-matched cohort design, matched on some of the variables that I've listed here, with outcomes that include things like pain management, goals discussions, and obviously hospitalizations and cost. Gathered a little bit of preliminary data, and these data are now in press at the Journal of Palliative Medicine. We compared a preliminary palliative home care program, which is basically hospice nurses providing skilled home care. So really no difference except that instead of a home care nurse, you have a hospice nurse. So it's really nursing expertise. Using a propensity score match, providing hospice nurse and 24-hour, 7-day triage. And because of the timeline, we looked at 30-day readmissions because that was data we could get fairly quickly. And we were able to show about a 50% reduction in 30-day readmissions with essentially, I'm simplifying a little bit, but essentially substituting a hospice nurse for a home care nurse. All of the other infrastructure was the same. So just substituting somebody with expertise in goals discussions, pain and symptom management, we're able to cut hospitalizations, 30-day readmissions by 50%. And that gave us some of the juice that we needed to go to CMS and say, well, what if we could add on additional services? Just think what we could do. But which services? Right, this is where it gets interesting. If you want to think about designing a palliative home care program for a patient like John, 54-year-old guy, metastatic colon cancer, lots of symptom needs, caregiver needs, which services would you focus on? So remember, these are the services that I showed you before. We were able to go back and look at our data and try to figure out which services were most important to patients and families. Case management turns out to be a different place on the list depending on how you look at the data, which is why what I showed you before conflicts with this. But this is a quick summary. And the one thing you'll notice that we noticed with some dismay when we looked at this graph is that a lot of the classic hospice services, a chaplain, respite care, a nurse, are really on the right side of the graph, meaning patients and families place less value on them. What they valued most were some of the things on the left side of the graph, things that both aren't part of a standard home care benefit or a hospice benefit and are a little bit more difficult to arrange. It's easy to get a nurse out to see a patient. It's harder to arrange the most popular item, for instance, which is arranging a voucher that lets patients and families pay for a friend or a neighbor to provide care. Not impossible, but harder to do, although much more popular, say, than hiring a home health aide directly. So our challenge was, how do we take these preferences? This is what our neighbors want. This is what patients and families want, and trying to translate those preferences into what we could actually offer. And it was a compromise process, frankly. What I just showed you would be the ideal home care program for patients with advanced cancer. What we put together is what we could put together, which is essentially nurse services and then some of these services listed here. So this is the core summary of what CLAIM offers. We've been looking very carefully at visit frequency, telephone contacts, after hours, emergency contacts, quality of care, including acute care utilization and cost. And just to wrap up, those are the data that I want to show you. Briefly, a couple of challenges we've encountered. The first one is really the biggest one for me, that this is serving such an enormous need, particularly in our health system. We've had a lot of patients come to us who are really, really, really sick. These are patients who even a hospice program, I think, would have difficulty taking care of. But there's really no other option for them, and so they come to us with multiple hospitalizations, with needs like intensive wound care. We're doing sometimes several nursing visits in a day. So these patients really have a lot of needs that are unmet, which is challenging for us to run a program, but really it's more important to me because it makes me realize there's an enormous need out there that's just not being met. Patients are much sicker as a result. It's hard to measure what we're doing in terms of hospice referrals. What I didn't tell you is about half of our patients are discharged from CLAIM to hospice, and their costs, their hospitalizations go way down. It's a challenge to measure that, but I think we need to. And our staff are really having a difficult time. We didn't really anticipate how needy our patients would be. Our staff didn't realize that either, and so I mentioned patients who are getting 2 or 3 nursing visits a day. There are nurses now who have to do 2 or 3 visits a day, and it's a bit of a challenge. But I think we're all excited, and this is all good news. So John was discharged to palliative care, spent the next 4 months, multiple clinic visits, but no hospitalizations, used home infusion twice, and I'm convinced that those home infusion episodes avoided what otherwise would have been a hospitalization. Transition to hospice, was on hospice for 6 weeks. That may not seem like a lot, but again, our median length of stay in hospice is only about 6 or 7 days. So he was on our hospice program 7 times longer than our typical patients are, and was able to die at home, which I don't think he would have been on track to do otherwise. And then family and his 2 daughters got bereavement services from us. So what does the future of palliative care look like? I think increasingly it's going to be home-based, and if we don't keep up with that home focus, we're going to miss out, and our patients are going to miss out. Increasingly needs to be population-centered. thinking less about getting patients out of the hospital sooner, thinking less about keeping patients from returning to the hospital, and really thinking more about the population of patients who are out there right now to try to do a better job at taking care of them at home so they don't need to come into the hospital in the first place. Increasingly integrated with inpatient and outpatient care through electronic medical records and other mechanisms. Increasingly quality-driven. I think we're going to start seeing more focus on palliative care quality, both inpatient and outpatient. And I think, as many of you know, we're already starting to see ways in which palliative care can be funded, and home care in general can be funded by cost avoidance and gain sharing. So thanks to many people that I've worked with, funders in the past, including CMS. Let me stop with this quote because I love it. I'm not a big science fiction fan, but I love this quote anyway. William Gibson is quoted as saying, "The future is here now, it's just not very evenly distributed." I think that works for a lot of innovation, implementation science that I wind up doing, but particularly in palliative care. And I'm willing to bet that somewhere in this room, somebody has an idea for better palliative care that 10 years from now, we'll all look back and say, yeah, this is logical, it's common sense, we should have been doing it this way all the time. So my last plea to you would be, fine, pay attention to me, certainly pay attention to Diane, listen to the discussion, but also look to your left and look to your right and look for ideas that are being harbored by your neighbor, in the outpatient cancer center here, in the community with Hospice of Delaware, Susan Lord's program. Look around for good ideas because this is where good ideas come from. Thanks.